Mr Deputy President, I rise to speak on the Abortion Law Reform Amendment Healthcare Access Bill. The Honourable Member brings this bill to this House with the stated aim of increasing access to abortion, especially in our regions. It is undoubtedly true that there are capacity constraints in our public hospitals, and not everyone is able to access everything they need, where they need. This is very true in the regions where patients know that they have to travel further than their city cousins to access a range of healthcare services. I agree that we need to do better with the provision of healthcare in the regions. But I do not share the Honourable Member's view that abortion is a special case for which special provisions should be made, or that we can fix up capacity constraints in the public health system one procedure at a time. And I can find no evidence that abortion is particularly hard to access in parts of New South Wales or comes with more onerous access barriers than many other medical procedures. We need to be sure that we are not voting for a bill which fixes a problem which may not exist. First trimester abortions are the most common, and overwhelmingly now they are medical abortions, procured by the use of drugs rather than surgery. Medical abortions are available through specialist clinics and GP surgeries, and are also freely available throughout New South Wales via Telehealth. The providers have even coined the term teleabortion to describe this service. A phone consultation is followed by abortifacient drugs received in the post. Teleabortion is available to anyone, anywhere in New South Wales, provided only that they can access a telephone and a letterbox. While it may address geographic barriers, teleabortion does not address the provision of adequate counselling for women or follow-up care. But these matters are not the subject of this bill. We can forget, when we talk about abortion only as healthcare, that for women who are faced with this decision, or who have had an abortion, that this is not just a moment in time. This is something they carry with them for the rest of their lives, and the need for follow-up care may arise years later. And this is not driven by guilt. It is usually profound loss, because no matter what the circumstances, it is an overwhelming sorrow to stop being a mother. And this highlights another issue I have with this bill. It presents abortion as a complete answer to women facing challenges in their pregnancy. Certainly, abortion terminates the pregnancy. But for most women, the problem is not simply that they are pregnant. It is that they are pregnant and their partner is unsupportive, or perhaps even coercive or abusive, or is threatening to leave them if they don't have an abortion. Or they are pregnant and they have insecure housing. Or they are pregnant and they are concerned what impact this will have on their career progression. Or they are pregnant and feeling very lonely and scared. Abortion deals with the pregnancy, but the and remains. And these ands are often issues which we, as a compassionate society, should also be addressing. There are services: Diamond Women, First Steps Pregnancy Support, Women's Life Centre, Lily Rose Pregnancy Support among them, which seek to engage with the whole woman and support her and provide strategies and supports to deal with the ands. But these are or underfunded and can be hard to access. First Steps Pregnancy Support in Queanbeyan, for example, can only afford to fund a social worker for 12 hours a week, but has seen a 100% increase in demand for its services this year alone. I commend the wonderful volunteers who make these services work for women. And if we are considering the issue of access to services for women facing challenging pregnancies, then access to these services, which see the whole woman and not just the pregnant woman, need to be part of the solution. Finding data about abortion numbers is very difficult, and no data, other than anecdote, has been offered to indicate the existence of any access issues. We have been told about an academic study by Dr. Anna Noonan of the University of Sydney, which apparently demonstrates the problems New South Wales women face when seeking abortions. But this study was a survey of only 16 participants, and as the lead author herself warns, quote, "This study has limitations. The findings of this study may not be generalisable to other parts of Australia or to other rural contexts," end quote. As such, it is not a strong basis on which to support sweeping changes to ministerial control of the provision of abortion services in public hospitals, nor to require faith-based facilities to change the care which they currently offer, as this bill seeks to do. I'm grateful to the Parliamentary Library for their help in researching the number of abortions in New South Wales. They could only find one publicly available report following the passage of the Abortion Law Reform Act in 2019. This report indicates that for the year ending 30 September 2020, there were close to 16,000 abortions notified in New South Wales, and they overwhelmingly occurred outside public hospitals. 80% of these abortions occurred before 9 weeks gestation, when medical abortion, teleabortion, would be medically indicated. No more recent New South Wales data was publicly available. Using Commonwealth Medicare and PBS figures, some interesting trends emerge. The rate of surgical abortions is declining sharply, with last year an 11.3% drop year on year. The overall rate of medical and surgical abortions is also declining, which frankly is what we should expect given improvements in contraception and easier access to contraception. Unlike the early 70s, there is no longer a marriage test to access the pill, and we can put condoms in our shopping baskets next to our cornflakes and check them out ourselves if we wish. Abortion is becoming less common, which is a good thing because it is the worst form of fertility management for women. There is no indication that abortion is becoming less common because of access restrictions. Rather, with better contraception, demand is falling. Again, this is a good thing for women's health. Much of the data the library used to calculate abortion numbers was from publicly funded Medicare and PBS figures, which also suggest the opposite of difficulties with access. But while demand may be falling, especially for surgical abortions, a significant number of abortions still occur. Extrapolating from this Medicare and PBS data and using ABS residence data, the Parliamentary Library helpfully estimated that about 22,300 abortions occurred in New South Wales last year. These were overwhelmingly accessed outside of public hospitals. The fact that we have to turn to Medicare and PBS data to calculate numbers underlines the fact that abortions are currently funded from the Commonwealth Health budget, and so questions of cost of access are perhaps best dealt with in that arena. This bill appears to seek to address a perceived access issue by requiring the New South Wales Minister for Health to open all of our public hospitals to abortion. We need to think carefully about this, because in effect, this could be cost shifting over 22,000 procedures from the Commonwealth Health budget to the state. Sadly, we don't have Albert the Magic Pudding, so we need to think about how our health dollars are spent. Balancing competing claims is a difficult task, and one which properly belongs to the Minister. This bill seeks to take that responsibility away from the Minister for Health. We all have our own private wish lists. I wish patients didn't have to travel from the Coffs region to Sydney for some cancer tests, but they do. Or that if you needed it, you could get bypass surgery in Wagga, but you can't. Or that the wait time for an iron infusion or cataract removal was not so long, but it is. The risk in this bill is that its implementation would lead to a significant cost to the state health system with a consequent reduction in some of our other health services. I cannot support this change. These difficult decisions of distributive justice and allocation of scarce resources properly belong with the Minister. Nor can I support the change to data collection and retention. This debate has been hampered by a lack of adequate data to support the claims of difficulty of access. In the data-rich world in which we live, and when we rely on access to data for so much of our decision-making, it is hard to understand why we would like to know less rather than more. One of the changes proposed by this bill to increase access is that the categories of those who are lawfully allowed to perform abortions in New South Wales be extended to include not just registered medical practitioners, but also nurse practitioners, endorsed midwives, and other registered health practitioners of a kind prescribed by the regulations. This extension is limited to performing abortions on women who are not more than 22 weeks pregnant. This may have been intended to allow nurse practitioners to prescribe medication which procures abortions. However, it is not drafted in this way, It is so broadly drafted that it would permit nurse practitioners to perform surgical abortions for which they have not been trained, provided only that the gestational age of the child in utero is less than 22 weeks. The bill also removes from the Crimes Act any sanctions against a registered health practitioner, who would no longer need to be a doctor, from performing abortions on any woman at 21 weeks gestation. It is not an overstatement to suggest that this provision, which removes existing protections for women, takes us back to the backyard. Let's sit with this for a moment. This bill would usher in the prospect of unsafe care for women. It would permit nurses trained to care for women in the birthing process and bring new life into the world, and not trained to perform operations, to perform surgical abortions on women, with no fear of the present criminal sanctions. This is unsafe, and in the name of increased access is a backward step in healthcare for women. We do not want, nor should we accept, women being operated on by health workers untrained for the operation which is being provided. I cannot accept a bill which would be so damaging for women's health. The bill also presumes that prescribing and monitoring medical abortion can be safely done by those not trained as doctors. I recognise that this view is shared by the TGA, but in the light of recent research, it is a view we need to reconsider. The largest known study of medical abortion was released last month. This looked at the experience of close to 900,000 women prescribed mifepristone abortions in the US between 2017 and 2023. The study found a serious adverse event rate of over 10% in medical abortion, including sepsis, infection, or hemorrhaging. Just over 5% of women, that's 1 in 20, required either hospitalisation or an ER visit. In the light of this research, the authors have called on the FDA to immediately reinstate the earlier, stronger patient safety protocols, the ones we currently enjoy, to ensure that doctors are responsible for the administration of medical abortion and that follow-up care is provided. For the sake of women's health, this is something which we should also consider carefully before rushing to dilute safety standards for women. And even if we could accept increased risk to women's health, this change would be unlikely in other than a theoretical sense to increase access to abortion. It may put a few more nurse prescribers into private practice or manning teleabortion phones, but for any fee-free prescriptions of abortifacient drugs, these consultations would still need to occur in our public hospitals. We know how strained midwifery resources currently are. This was made very evident in the Legislative Council inquiry into birth trauma. And there are real questions of resource allocation and the wisdom of the state budget absorbing existing Commonwealth health spending. The bill also identifies medical practitioners whose consciences will not permit them to cooperate in an abortion as a barrier to access, and seeks to control the way in which our doctors and nurses are able to exercise their consciences. There is tantalisingly little evidence to support the underlying assumptions on which this argument is built, which appears again to rely on anecdote rather than concrete examples. But even were it to be well-founded, we should resist any attempt to weaken the legal recognition of conscience and conscientious objection. We have a long tradition in Australia of recognising and even celebrating conscientious objectors. We still teach our children about Simpson and his donkey and the courage he showed as a pacifist conscientious objector in the Gallipoli campaign. He is as celebrated as any of our diggers. We've always recognised that we are stronger as a society when we allow our conscientious objectors to keep asking that question posed by Martin Luther King Jr. Is it right? And in abortion, our doctors who are conscientious objectors are asking that most fundamental of all questions. If I am to take a life, is it right? We have always allowed conscientious objection to the taking of life. Think about the structure of a firing squad. Why a team rather than just one man and a rifle? Because it allows for members of that execution team to be conscientious objectors to the taking of a life, to aim high, to shoot wide, or to load their gun with blanks. And this explains why on occasions a prisoner facing a firing squad does not die, because everyone on that squad had a conscientious objection to the taking of a life, even when that was the life of a convicted criminal. Within our political parties, we preciously guard the right to exercise our consciences on matters of life. Why would we claim for ourselves a right which we are not prepared to accord to our medical colleagues? If we vote for this provision, it would be tantamount to an Ionesco script, absurd both in concept and in performance. And what would we gain? As a practical matter, probably a number of medical professionals leaving the profession or choosing to work elsewhere. As one Sydney GP has commented, I do not think the passage of this provision could stop some of us from practicing medicine altogether. I do think the passage of this provision could stop some of us from practicing medicine altogether if we are obligated to make a call or a referral that, in all conscience, we do not want to make or perform or assist in a procedure we are unwilling to do. And this is not theoretical. I've been contacted by a number of midwives in relation to this bill. They tell me that at least one major public hospital in Sydney, about a quarter of the midwifery staff are preparing to leave that hospital if this bill becomes law. And in practical terms, this will only increase access problems for women, whether they are seeking abortions or seeking to deliver. And if we say to doctors, oh, look, you're too scrupulous, you shouldn't be so particular about not taking a life, it's only a bunch of cells at 10 weeks development, you're wrong to have a conscience about such matters. Does this help us as a society? Surely we are best served by medical professionals who see each person before them as a unique individual, who see our infirmities and our disabilities but do not reduce us to these, but have the capacity of seeing the unique life in front of them. We are best served by doctors who can see even the youngest of lives and still see and respect the humanity, the life in front of them. And ultimately, this argument comes down to that life. Because even at 10 weeks gestation, we are dealing with another life. This is not a matter of belief. I do not believe that a 10-week-old fetus in the womb is a living human being. I know it is. Just as I know the Earth orbits the sun and gravity stops us from falling off the face of the Earth. I know this because it is scientific fact. Nothing has been added to any one of us since our conception except food, water, time, and hopefully love. It is remarkable to me that at 10 weeks, the fetus will be the size of an apricot, and many casual contacts may not even know that the mother is pregnant. But the child that she is carrying will have a recognisable face, a heart which beats, tiny fingers and toes, and even fingernails and toenails. I'm amazed by the research that the child in utero can hear the outside world and respond to its mother's moods. So if the only time when you relaxed with your feet up and a cup of tea while you were pregnant was when you were watching your favourite TV show, the theme music of this TV show will calm your fractious baby because it heard this music in the womb and responded to the spirit of calm in you. The question then becomes, how can I deal with this life? As Martin Luther King Jr. framed the question, what is right? Is it right to take a life? On my conscience, I know I could not take the life of another, nor could I facilitate it by saying, I won't, but let me give you the phone number of somebody who will. And I do not believe that I should require doctors or nurses to do what I cannot. And so I cannot support this bill.